This is the case of Bush. Bush is a 12-month-old Labrador female intact with a 2-day history of vomiting and inappetence. Bush has now become lethargic. On physical examination, the abdomen palpates slightly painful but is still flaccid. It was also noted that the vulva was swollen. The initial diagnostic plan was to obtain radiographs of the abdomen, possibly followed by an ultrasound or an upper GI series, depending on what was found on the plain films. This is a lateral view of the abdomen. Note that the stomach is moderately distended with gas and fluid, and that numerous small bowel loops are also moderately distended with gas and fluid. Several of the small bowel loops in the mid to caudal abdomen appear to be stacking longitudinally as well as axially in relation to the animal. No evidence of a radiopaque foreign object is seen, and the remainder of the abdominal organs appear to be normal in size and shape. Also, no definitive evidence of peritoneal fluid or free air accumulation is present. Because the entire abdomen would not fit on a single film, both a cranial and caudal VD view of the abdomen was obtained. On the cranial image, the stomach remains moderately dilated with gas, as well as numerous small bowel loops remain moderately dilated with both gas and fluid. In the caudal abdomen, again, numerous small bowel loops are present. There is also a lack of feces within the colon, which typically lies to the left of midline. Close inspection of this region of the colon to the right of midline shows either an abnormal opacity within a small bowel loop or possibly feces. However, again, this is on the wrong side of the animal. In close-up on the lateral view in this same region, there are atypical gas patterns that are either within a small bowel loop, which can be seen here dilated with gas, or possibly within the colon. However, these atypical gas patterns are not longitudinally oriented in a typical pattern that would tell us that it is colon. On the VD view, in close-up, there are lucent areas that parallel each other in this questionable area of bowel. In summary of the Röntgen signs, there are numerous moderately and diffusely dilated small bowel loops throughout the abdomen. Some of these small bowel loops are stacking upon each other in the mid to caudal abdomen. The stomach is moderately distended with gas and fluid. However, no evidence of a definitive radiopaque foreign object is seen within the stomach or small bowel. There does appear to be an atypical gas pattern within a segment of probable small bowel in the caudal abdomen to the right of midline. At this time, we have a revised diagnostic plan that includes an ultrasound of the abdomen or possibly an upper GI series, depending on what we see on the ultrasound exam. The ultrasound exam is chosen prior to the upper GI series simply because it is less expensive, quicker, and easier to perform. These are several images from the ultrasound exam of Bush. Note that the image on the left, there are at least 2 stacking or parallel-oriented small bowel loops that are fluid-filled, seen within the mid-ventral abdomen. Slightly further caudal, a same fluid-filled section of small bowel is adjacent to another section of small bowel that either contains gas or an intraluminal foreign object. Both of these images were obtained in a transverse orientation. When flipped longitudinally, the suspect intraluminal foreign object, seen previously on the transversely oriented image seen here on the left, now becomes linear as well as definitively intraluminal, suggesting that it is not gas and most likely is an intraluminal foreign object. Bush was then sent for surgical exploration under the strong suspicion of an intraluminal radiolucent foreign object that most likely is causing a partial obstruction of the small bowel. At surgery, a 4-centimeter length of corncob was found in this section of small bowel in the caudal abdomen and was subsequently removed. This is a chart that will help differentiate a mechanical versus functional ileus on plain film radiographs. As you can see with mechanical ileus, the amount of distension of the small bowel is typically moderate to severe, and the distension is typically regional. With a mechanical ileus, it is very common to see hairpin, very tight turns and stacking small bowel loops. Also with mechanical ileus, you may or may not actually see the radiopaque foreign object. With a functional ileus, on the other hand, there is typically mild to moderate distension of the small bowel loops, and the pattern of distension is diffuse. Typically, there are lazy loops where the small bowel loops turn, in contrast to mechanical ileus where there are hairpin turns. Typically, with a functional ileus, it is rare also to see stacking small bowel loops, and again, you may or may not see a radiopaque foreign object within the small bowel. Typically, the decision tree for possibly mechanically obstructed animals includes a good history and physical examination, followed by plain film radiographs. Oftentimes, a decision to go to surgery or not can be made just off of the plain film radiographs using the chart that was mentioned previously. If not, or if there is still equivocal findings, an ultrasound examination of the abdomen is typically chosen next, again, as it is easier to perform and less expensive for the owner. There are times, however, when the ultrasound exam is also equivocal, and when this happens, an upper GI series using barium solution typically needs to be performed. Keep in mind, however, that if a gastric foreign object is suspect, consider doing a negative contrast gastrogram. By shooting opposite lateral views and a VD view with gas within the stomach, oftentimes one can outline and diagnose an intraluminal foreign object within the stomach. This does not work if the foreign object is within the small bowel. Also, if there is a foreign object that is suspect to be within the colon, gas can be placed within the colon, again to help outline the foreign object. However, if a foreign object is found within the colon, surgery is not recommended, as most objects that are found within the colon or cecum will pass on their own.